reminder that we are being live recorded, so your laptop and your phones may fall on the camera, so therefore be careful. Okay? So, as ever, you can start the recording. As ever, we will be starting the meeting by introducing ourselves. Okay? I am Councillor Paul Egil-Shelvan. I chair the meeting.
Hi, I'm Graham Sayers. I'm GP in ANIC and Clinical Lead at the ICB.
Morning everyone, Jill O'Neill, Exec Director, Public Health, and if people wouldn't mind popping the microphones on when they say hi, just because it's recorded, thank you.
And I'm also portfolio holder for Caring for Adults.
Morning everybody. Oh God, that's
well done, you remembered.
How do I turn it on? Clearly, just the button. I'm Kevin Waring, I'm Superintendent for Northumberland and North Tyneside. I'm pleased to be here, thank you.
Morning colleagues, I'm Graham Wright, I'm the Director for Children's Social Care, Young People and Families at the Council.
Morning everyone, I'm John Lawler, Consultant in Public Health at Northumberland County Council.
Morning, I'm Paul Conway, I'm Temporary Head of Prevention, Northumberland Fire and Rescue. I'm representing Graham Binnon, who's at an NFCC conference today.
Please, sorry, 1 minute. Please make sure the mic is on when you speak, and once you've spoken, please switch it off. Thank you.
Morning all, I'm Jeff Watson. I'm a County Councillor and the Cabinet Member for Healthy Lives.
Hi everyone, my name is Lynn Patterson. I'm Deputy Director for Northumberland Place as part of the ICB.
Hello all, Neil Bradley. I'm the Executive Director for Adult Services at the Council.
Good morning, I'm Chris Jenkins. I'm Deputy Director of Planning and Performance for Northumbria Healthcare. I'm here representing Alistair Blair.
Good morning, I'm Brian Moulder from Northumberland CCG, that's the old days, Graham, from Newcastle Hospitals, and I'm representing Victoria McFarlane Reid.
Peter Stanfield, Chair of Health Watch Northumberland.
Abby Conway, Chief Exec of Citizens Advice, representing the VCS Commission, Thriving Together.
Morning everyone, Audrey Kingham, Exec Director for Children, Education and Young People in Northumberland.
Veronica Jones, County Councillor for Ponteland West and Cabinet Member for Improving Public Health and Wellbeing.
Hello everyone, Jim Brown, Consultant in Public Health at Northumberland County Council.
I'm Leslie Bennett, Democratic Services.
And so apologies for absence, Leslie.
Apologies from Graham Binning, Alistair Blair, Victoria McFarlane Reid, Councillor Rena Thompson, Sam Renison, Glenn Sanderson and Liz Simpson.
Thank you very much. So may I especially welcome the police, Kevin Waring, because this is the first time they are officially participating in our Health and Wellbeing Board meeting, so welcome. Pass on our greetings to Sam Renison because officially she is the member of this board. Now, minutes. Can I pass the minutes attached as a true record of what happened the last meeting? Yes. Thank you very much. Now the disclosures of interest. Is there any disclosure of interest? None so far. Thank you very much. So now we move into the main agenda item. So as you know that we are revising our health and well-being strategy. It has got four themes. Today we are going to discuss the two themes. The first one we will be discussing will be an adapting a whole system approach to health and care. That will be presented by Dr. Jim Brown.
Thank you, Chair. Thank you very much. As you know, we're halfway through the Joint Health Wellbeing Strategy, and I think what we've been asked is to kind of update against the achievements over the past 5 years and refresh the actions, the priorities, the indicators going forward. I'm not going to dwell on this because thank you, Chair, for just saying, you know, this is one of 4 themes that were originally in that 2018 strategy. Worth actually commenting, there's those 3 cross-cutting themes. We don't want to forget those around improving mental well-being, resilience, supporting people with long-term conditions, and exploiting digital technology. I'm hoping we've to some extent incorporated that. And just that reminder that the overall outcomes around improving life expectancy, healthy life expectancy, and crucially those inequalities. And I'm hoping that what we cover here contributes to those aims. The outcome, which remains unchanged really for this theme, is to maximise the value from and the sustainability of health and social care and other public services for improving the health of the people of Northumberland, reducing health inequalities. So the 3 priority areas that were agreed in 2018. And we're going to keep the first one the same, if that's okay with all of you, to refocus, prioritise prevention, health promotion. I think that's, I mean, you could change the health promotion kind of to community approaches, to community-centred approaches, but broadly, happy with that. The second one was improved quality and value for money in the health and social care system, brackets integration. I want to make some changes to that because, of course, integration is just one possible way of improving quality. It's not the only way. And then we'll make some minor changes to the third priority, which is around reducing those healthcare inequalities, and that's really, really timely. One of the things, obviously, there were perhaps wasn't as clear an action plan, and I think this is probably true of the Joint Health and Wellbeing Strategy, and partly we moved into COVID, so actually that wasn't firmed up. But what I'm really pleased to say is actually, and I'm hoping the achievements which we put in the report, which I'm not going to go through, you'll be pleased to know. I'm hoping they're there for you to read. But actually, there has been a lot of progress met against what the sorts of actions we agreed to take, and I'm commenting on some of the indicators of progress as well, where it's possible to do so. Just that reminder, I think Health and Wellbeing Board, you were happy with each thematic area, but just wanted that refresh of those priorities, actions and indicators, and just updating on achievements. I'm pleased to say System Transformation Board, quite a few of the members are here today, so apologise for any repetition. That's also the place committee of the North East North Cumbria Integrated Care Board. They agreed to take ownership back in April of this theme, and we set up a task and finish group that had good representation really from right across different sectors, different organisations, and this is a report from that group. It was presented to the System Transformation Board just last month, so we didn't incorporate their feedback into the report, but I'm hoping I'm just kind of can give a little bit of a fresh, and we've got the chair of the System Transformation Board here as well for where the discussion went. So where are we now? I think let's start with the really good news, which is what's happened to adult smoking prevalence. I mean, that's actually 30 years ago, 30% of our adult population smoked. Now it's 9.6% in Northumberland. So that is a phenomenal improvement, probably and remains the biggest thing that we can do to improve the health of the population, reduce inequalities. So, and actually we're better than England. We broadly most of the time have been. I think, it's partly because of small numbers. You can never be, it does fluctuate. But actually we've seen that continuous decline in adult prevalence of smoking. Only thing is, I would caveat that if people in routine and manual occupations still smoke, over 20% of the population, and that's got to be a real focus for where we go next. So that's, some of the good news. Always got a caveat that we're never going to celebrate until we want to get to 5%, and we want to reduce those inequalities in adult smoking prevalence. For alcohol-related admissions, unfortunately, it always makes it frustrating public health, the data method of calculating changes, but broadly, actually, that wasn't really going in the right direction up until most recent data, and we still remain, as across the whole of the North East, significantly higher than the England average, so a real focus needed. For physical activity, sort of a mixed picture. We've seen improvements actually in the proportion of people doing that 150 minutes of moderate or vigorous activity in a week. We've seen improvements in the proportion, and we're higher than England average. But actually, it's really crucial to get those people who are inactive, people doing less than 30 minutes moderate activity in a week, where it's been quite flat. Now, self-reported well-being was included here, and that's the proportion of people with a low satisfaction score. It's broadly similar, it's slightly worse than England average, but actually we saw a real worsening during COVID, I think perhaps not surprising for many of us, and that has improved a bit, but actually generally it's slightly worse. We're obviously going to pick that up in the resident survey as well, but you know, we're suggesting actually that comes out of this, because it's not really a measure of this single theme, it's actually a cross-cutting measure. So we can come back to maybe, you know, what we had as cross-cutting measures, still really important, but not specific to this theme. When we think about that second priority, which is around integration, again, a kind of really interesting mixed picture. For those kind of social care-related measures around social care-related quality of life, carer-reported quality of life, really important. And the people who use services who feel they have control over their daily lives, that's really important. Really control is kind of really strongly correlated to people's quality of life and their life expectancy. There's been a fairly flat picture, but we remain better than the England average, so that's really positive. Again, we don't necessarily have the data on the delayed transfers of care in the way that we do. It's measured in a different way. We can't benchmark it as a local authority against other areas. That was increasing in the beginning of the health and wellbeing strategy, and until we were able to measure it. And it was increasing, but we remain far below, I think, and I think it's probably safe to say even now we remain well below the England average. Permanent admissions to residential nursing care homes, so that was reducing, obviously through COVID, and I think some impacts of COVID have had on that, but we remain higher than the England value. I think in the past year it has begun to creep back up, as has been reported, I think, in other reports, but you know, generally been on a decreasing trend over the 5 years. So what I'm not going to do is talk about, as I say, the achievements, but happy to sort of take questions where I'm able. What we tried to do is collate, I think, from people right across the sector, you know, what were the things they felt had gone really well or not so well, where had we achieved. And I think what I've tried to, you know, is just capture a few kind of case studies, a few stories about, you know, where we've seen improvements. But I'm going to move on because I think that's the focus of discussion, to what are the kind of changes we want to make, and really invite your comments and discussion if we can, Chair. I think it's worth just reflecting. We're in actually a really different place. I mean, it's always like this, isn't it, in our worlds and council or NHS worlds, that the whole kind of context changes. But certainly what, you know, major things, obviously the introduction of integrated care systems, integrated care boards, the fuller stock take of general practice. I think that had some really relevant points about integrated neighbourhood teams that we're going to be picking up. You know, Marmot has reported 10 years on, and I think all of our organisational plans and strategies have been updated. But I'm really pleased to say, actually, there's an alignment around inequalities, and that's really, really important. And I think that's got to be the focus for all 4 of those themes. So the minor change I want to make is, because integration isn't the only possible method of improving quality, we'd like to change that second priority to drive integration, personalised care. We know that's effective, improving the quality of care. And really, the important addition is embedding user, patient, resident involvement in planning, commissioning, delivery of care, and actually also in their own decisions about people's individual care. That's strongly associated with improved quality of systems. And then some minor changes to that third priority, really just to incorporate not just access, but experiences and outcomes from healthcare, health and care, and just this kind of minor changing, equitable and fair, broadly mean the same thing. So actually, you know, that it makes sense just to kind of keep it pithier. I think one of the other things about COVID that happened, you know, one of the huge successes actually of the past 20 years is a reduction in deaths under 75, what we call premature deaths, from mainly heart attacks and strokes, cardiovascular disease. That halved over that time. That was particularly down to reductions in smoking, but also you know, changes in other risk factors, and also early detection of things like high blood pressure and control of it, atrial fibrillation, irregular heartbeats, and you know, and high cholesterol. But what we saw in COVID, it was kind of then flattening a bit during the 2010 to 2020. And then in COVID, we saw actually a marked increase in mortality. And what was, I think, most worrying is that that increase was highest amongst, you know, our communities in England living in the most deprived areas. for a variety of reasons. So one of the kind of additions here is not only, and I think, you know, the priority remains around what we call primary prevention, stopping people getting ill in the first place and promoting people's health, promoting well-being, thinking about how the communities in which people live. And that's got to remain a focus around tobacco, alcohol, healthy weight, physical activity. You know, probably the four biggest things that impact on our health, impact on costs, impact on our well-being, but also to, again, what we call the secondary prevention, the early identification and management of some of those risk factors. That's really important. If we just think about sort of the cost of personal social care, it's about 50 million a year for Northumberland from people who've had a stroke. So actually, it's so possible to prevent, it's really got to be an additional priority. And that's kind of in keeping with, I think, the strategic context, the major conditions strategy nationally as well. So a lot of the indicators we've kept similar. We've kept making every contact count as a major priority, and I think that's, you know, that there's been some great successes there, and that's really just cross-cutting, something we can do right across the system, but added in a couple of indicators around the secondary prevention of cardiovascular disease. And really importantly, some of groups, people with severe mental illness, people with learning disability, they die younger and get risk factors and illness earlier than the rest of the population. So, and we've done some fantastic work actually, particularly primary care colleagues, but right across the system in maximising the health checks, improving their health, and that's now also a priority added in here. The issue about social value, maximising our social value responsibilities, I think all of our organisations recognise that, and that's in everyone's strategies and plans, and just wanted to get that, and that this is pulled from the inequalities plan into this priority in the action plan as well. I was just reflecting when I was going over my notes today that perhaps it's not just about large employers. You know, it's not just about NHS and the police, Northumbria Police, and the council. It's actually about some of our smaller employers as well. You know, general practices, some of our small businesses, some of our pharmacies. Actually, all, you know, we have so many small businesses in Northumberland. All of us, if we can keep the pound in Northumberland and improve the health of our people who work there, people who for whom we, you know, procure equipment and other supplies, that's going to have a massive impact. Now, the second priority around integration, coordinated, personalised care and user and resident involvement in health and social care. One of, I think, the big ticket items is around integrated neighbourhood teams. That was in the Fuller Stocktaker General Practice. But what I'm hearing in the discussions we've had is actually the strong endorsement right across the system. We've heard that from Northumbria, we've heard that from Cumbria, Northumberland, Tyne and Wear Mental Health Trust. We've heard it from primary care. We've heard it, I think, from council adult social care teams and public health teams as well, that actually focus at place is really important. I think there are some challenges around what the geographical footprints will be, and that'd be something that we might want to kind of discuss today as well. Again, pulling from the inequalities plan, just having a system-wide intelligence strategy, using population health management approaches, and trying to link, which we're using data better to improve health and reduce health inequalities, and trying to link some of those data sets. That's a real aspiration we want to take forward. And then, as I said, that service user, carer, patient, resident involvement in planning, commissioning, delivery of healthcare, and in decisions about their own care. That's what we wanted to add in there. And a big thanks to Healthwatch for some of those indicators, because that's actually really quite specific. Probably really challenging for us, actually, and we, you know, welcome that comment. But actually, if we could get that right, we would be improving care, and we would be empowering some of our patient service users and residents as well. There we go. There we are. We're back in the zone. Back in the zone. I thought I couldn't hear myself talking back to myself. I think one of the problems we have at the moment is actually lack of data, lack of dashboards around our healthcare inequalities. And what's really welcome actually is that Northumbria have developed a healthcare inequalities dashboard. So it seems to be coming and going a bit. I'm going in and out of range. Is it? Okay. I think yeah, that sounds okay. So what we'd like to see is actually right across the system where we can capture some of those healthcare inequalities. One of the indicators that we did have was around inequalities in hip and knee, common surgical procedures, hip and knee replacements. The problem with that is that if we don't adjust for age, what we see that inevitably in our more affluent communities where people live longer, people are going to get more severe arthritis and require hip and knee replacements. So it's really got to be standardised. So I think the starting point is just that monitoring. We've got to get that data. We've got to kind of embed that in everything we do. And I think that's the same for what we call health equity audits, so systematic approaches and programs where we're actually looking at those inequalities in terms of what we do, in terms of access, experience and outcomes, and then take actions to address those. We've done them for certain things like, for leisure provision and for NHS health checks, and I know certain other areas have done that, but if we can just systematise that would be fantastic. And then there's another fantastic opportunity around uptake of screening and vaccinations. What we have is actually really high levels compared to other areas in Northumberland, but we have marked inequalities, much as we do for some other areas. But that's a real opportunity where we can take on some work. So final slide, I just wanted to feed back, and it can help us out here, Graham, just from our discussions last month at the System Transformation Board, who is going to be the kind of owner of this theme. I think I'm really pleased actually there was an appetite to make sure we've got sexual and reproductive health and drugs in there as well. And I think that's, in terms of drug strategy, really important in relinking, with our police colleagues around the, violence and approaches to reducing violence. And that's, it's a whole system approach which is required. And with the women's health strategy, that's really relevant, the sexual and reproductive health as well. One of the things was, of course, what we didn't really have the time to do was actually capture views, but we did try to make sure that we were, using the people who are on our task and finish groups to capture the views that had already been from engagement. And one of those was one of the big things around dental access. Where does that fit in? It doesn't kind of naturally fit, but that's actually really important. How people, access to dentists in some of our areas is a major issue, but that's actually that doesn't naturally fit into any of our priorities. But how can we make sure that we are working as a system? And I think there's lots of opportunities with it now resting with the ICB to move forward on that. Strong endorsement for integrated neighbourhood teams. It was great to hear actually from Audrey that schools would really welcome that as well, because that's everyone's part of that place, part of that community. But again, what kind of geographical footprint are we going to look at? It's better to have kind of those small place areas, small towns, Blythe, Ashington. That's what would work. That need to kind of dovetail. I think it'll work well at Health and Wellbeing Board, but just making sure there's lots of overlap and there's lots of dovetail in terms of communities first, in terms of community-centred approaches. That's actually relevant to all 4 of those themes, not just kind of within that empowering communities, people and communities theme. And then just to say, once kind of agreed here, I think we're going to kind of think about some of the monitoring implementation back at System Transformation Board once we've kind of agreed it here. So a few questions are a little bit of, well, who's going to lead each of those actions and who's going to kind of take responsibility? But no one can do it alone. So there's a little bit of, some people need to take things forward and own it, but others need to collaborate and support. And actually it'll only work in that way. We're never going to achieve what we want to do if we're doing it on our own. How can we bring that communities first approach to what we're doing? What things can communities do for themselves? Where do people communities just need a bit of support and where actually the services need to take the lead? And really, how can we accelerate change? Because I think some of these are really difficult about how you link data sets, how we get healthcare inequalities dashboards. It takes time, but actually it kind of needs momentum to get it to happen in the next 5 years. So on that, I'll hand back to the Chair and happy to take questions if we've got time, Chair. Thank you.
Thank you, Dr. Thank you, Dr. Jim Brown. Thank you very much. I think this is this particular theme is very close to my heart because I was leading it, and we have done lots of progress. I think mainly in 2 dimensions. So one in tackling inequalities, health inequalities, like for example, the smoking, reduction of smoking is a good example. And also as a board, Secondly, we have been building a good infrastructure, aren't we, Jill? I mean, because our aim is to tackle inequalities in all forms, health, crime, and everything. So we have been incorporating lots of units like police, and then before that we had fire officers. Now I think Thriving Together is joining us as well. So in that sense, we are also building infrastructure. So at the moment, we are to look at the comment on the achievements and then agree on the amendments to priorities proposed by Dr. Jim Brown. So I will let the floor open for questioning, please. Yes.
Thanks, Jim. It's good to hear it twice because it takes a bit of getting your head round, to be perfectly honest. And having it at STB and then here certainly has helped me. There's an awful lot of discussion about integrated neighbourhood teams, and it strikes me that all of our organisations have a slightly different picture in our head about what they are. It does beg the question, how will we know when we've got one? So what is the scope of them? And I think Lynn had a good point. We were talking about this at the primary care GP collaborative meeting last week, and it was, do we know what tasks would be best done with an integrated neighbourhood team? And if it's going well, how have we measured that? Because there's a process involved in developing these things. And the other thing that always comes out of this is the business intelligence and the monitoring. And in some aspects of health, we have risk registers about whether we're making progress against our indicators. I don't think we've had a risk register approach to the intelligence that we've got along this type of thing, perhaps. And if it was STB's perspective, I think having some kind of more tangible progress reports to some of this, and that comes back to, well, whose responsibility for providing that? And the final point was on the integrated neighbourhood teams. How do we make sure that's not just us as service providers integrating, and how do we do that with the community at the same point? And I think the challenge in Northumberland is we've got so many different geographical pockets, and the service providers look at that and think, goodness me, I could never spread myself so thinly across all of those. So how do we do that? So it is a challenge for us, I think, but needs some thought between us all about how to achieve that.
I'm very interested in the dentistry part of putting things together, and some of the problems I think in dentistry are indicative of some of the other problems that we've got, mostly about geography and the isolations you just touched on, of places, I don't know, somewhere like Keele. How do they ever see a dentist, or how do they ever get to a gym? How do they ever get to a swimming pool? It's a real issue that we struggle with. We are trying to do something. I think we're managing to do it with our libraries, which I still think is part of the health and well-being of the people. But it's a real issue for us, and particularly dentistry keeps coming up time and time again to me. I mean, I was talking recently about service families, for example, who get posted to Albemarle. There's probably 200 service families. By the time they get on the dental list and find, well, I think you said the last meeting, Health and Wellbeing Board, at the moment you couldn't recommend a dental place anywhere in Northumberland. So a service family coming here from Aldershot or something has got no chance of their kids seeing a dentist, and they're here for 2 or 3 years and they go away again. And it's a real issue that's just not going away. And you're saying who's going to be responsible for it? I don't know. I can't seem to get someone to really take charge of that issue. I know what it is. We all know what the problem is. There's not enough dentists, but I don't know how you solve it, but it keeps coming up.
Thank you, Chair. Yeah, I mean, I was going to double down just on Graham's comments around the neighbourhood teams, really. I think there's a danger this one could drift if we don't get control of it. What will we do in a neighbourhood team? Who will be in a neighbourhood team? How many different organisations are represented on it? I think it's crying out for a subgroup. I mean, whether that's done under the STB or whatever. And I'm going to partially burn a colleague here in terms of who I think should lead on it, and they'll probably get their revenge in a month's time or whatever when the next thing comes up. But I think the ICB is very well placed to sit over that, to be honest, with the links into all the parts of the NHS, which are obviously key contributors to that. You know, we have the conduit through the local authority that Jill, Audrey and I can coordinate, but we need a series of experts sat around a table coming back with a set of recommendations there. That isn't going to happen in this sort of chamber. It needs to be thrashed out in detail. So I just say I think a subgroup needs to be set up as quick as possible, because I think we're all bought into the principle of it, and it will just drift if we don't get our teeth into that. Sorry, Lynn.
No, thanks for the challenge. But I do think you're right. I think the ICB can sit as that impartial voice across the system, and I think can support lots of different organisations. I think the discussion that Graham highlighted was that we really need to identify what is a neighbourhood team, first of all, because we have lots of community organisations, family hubs. Do you know, the premise of what was in the past was Sure Start. Who knows what's to come next year? Do you know if there's political change? So all of this, we could start the ball rolling, but I think it's really important to engage with our communities to figure out what they want locally, and let a little bit of organicness come to those discussions, because I think that needs to be led by what's needed locally. But yeah, I take on the challenge of thinking, yes, the ICB would probably be one of the better people to sit and be impartial to those discussions.
Thanks, Chair. Thanks, Jim, and thanks to the group that you work with, because I think it was a pretty difficult challenge that we set ourselves at the back end of last year to review the document. It's taken quite a bit of honesty and reflection, I think, about how we actually write strategies in the first place and what we put down. And I think a big challenge for us is, if we fast forward in 5 years' time, will we be able to answer all of these questions that we're setting ourselves the task to be able to do, to show the change that we need to do? If they feel a lot more tangible to me, bearing in mind what we've just said around the neighbourhood teams, but I think a lot of the indicators feel much more measurable. Something that I'm particularly keen to do, because we said we would do it in the inequalities plan, is where possible have closing the gap indicators, not just at Northumberland level indicators, because we know we can. Your smoking prevalence was a primary example of 9.6% prevalence across Northumberland, but when we go into different communities, we've got much higher prevalence in some areas. So I do think there is a piece of work to do about where we have that data across our organisations. Can we share it to best effect? I think fully endorse and support the sexual health interface. I think the question to take outside of here for the drug strategy work is the link across to the Safer Northumberland Partnership, because they are a responsible authority and statutory partnership as well that have direct responsibilities to look at drugs and alcohol. So we just need to make sure, again, we don't over complicate things by duplicating effort and coming in here and coming in Safer Northumberland Partnership. So I do think that's the one that we need just to tease out in a bit more detail. And just to go back to Councillor Watson's point around equity and access, that is a particular challenge for us in Northumberland, which is why we've said throughout our inequalities focus isn't just on socioeconomic or protected characteristics. It has to be that rurality lens for us, and we won't achieve it in everywhere. Kielder is a particularly complex example, and that's why you use it, because we can't have all services for such a small population. So how do we either think differently, or do we accept, to a certain extent, some people have chosen to live in very rural, remote communities? But the dental access is within the ICB. We've got a particular person, Pamela Phelps, leading on that very challenging piece of work, which is a national concern for us that we are looking at locally. So I'm sure there will be further updates specifically in relation to dentistry, but it is incredibly complicated. I don't know if, Lynn, if you want to say any more about that, but overall, I think Jim and colleagues, well done on this, and I think it's about how we then pull it across all 4 themes, which we will do by February, just to make sure that there's some synergy across them all as well. So thank you.
Okay, so we agree for the proposed amendments. Okay. So I think the 5th point for me is important. I think it's gone. Well, once we agreed here, we need to have some monitoring mechanism of how STB really does it, and then we need to create some kind of a schema by which we are able to monitor and interact and then just oversee their implementation. So that should be done something in November. All right, thank you very much. Yeah. The next one is the other theme. Okay, it's ready now. Best start in life. Yeah. So they are going to, this is one of the other themes in our strategy. Graham Reiter and John Lawler will be giving a joint presentation.
Morning, everyone. Thanks for the introduction. Morning, everyone. Thanks for the introduction. I'm John Lawler, one of the consultants in public health at the council, and
Graham Reiter, Director for Children's Social Care, Young People and Families at the council.
In a similar way to the previous presentation, we've reviewed this theme of giving children and young people the best start in life. Graham and myself have been the officers and director leads for this, but we have been supported by Councillor Wayne Daly as well, who's had some input and provided some feedback and challenge to the theme. I'll share this slide again and for a different purpose. These are the overall themes as we've previously discussed. I think one of the key themes, or one of the key things which we would want to state from the beginning, is that theme 1, giving children and young people the best start in life, places a really clear emphasis on children and young people, and in our opinion, rightfully puts them at the forefront and centre of the joint health and wellbeing strategy. I know that we're all familiar with this, but it probably is worth reminding ourselves that the foundations of every aspect of human development are laid in the early years and built on throughout childhood. So we can't consider addressing inequalities, including health inequalities in adults, without addressing children. So it is paramount and fundamental to the strategy. And the Marmot Review, which was pivotal, identified giving children and young people the best start in life as the highest priority area in tackling wider inequalities. The way that we've approached this theme is probably in a similar way. We've looked at the indicators which are assigned to the theme. We've looked at the progress against those indicators, but also considered qualitative data from annual reports, external inspections. But really importantly, this hasn't just been a council-focused exercise. We've built on some extensive partnership working, which has been happening concurrently to review the priorities for children and young people. And that's been undertaken in the multi-agency Children and Young People Strategic Partnership, and also in Northumberland Children and Adult Safeguarding Partnership. And that work has been to identify and review priorities, but also to align governance arrangements for services and partnerships. It's probably important to also acknowledge that that work is still ongoing. And I don't know if you wanted to comment on some of that work, Graham.
Yeah, I mean, as I say, it's working concurrently, but just taking the whole systems approach, and again, making Jill's point that we want to try and reduce duplication. In the children's world, as across the piece, there's a range of statutory partnership functions that we all have to have, as well as council statutory functions. And we've used this piece of work in a sense to all the work of those separate partnerships has contributed to our understanding of how we've progressed the health and wellbeing strategy, because they all are key contributors to that. But similarly, we've been trying to streamline and clarify the range of, at times, disconnected governance arrangement that exists in the children's world. So John's already talked about the safeguarding partnerships in Northumberland. We have integrated our adults and children safeguarding partnership, which we think is a strength. I've got to say we've had some national views of how we set up the scrutiny of that partnership from the Department for Education very positively, but also our other partnership arrangements like Children and People Strategic Partnership. Also, we've got within the Council Education and Strategy Board, Work for Children's Social Care, which is the responsibility of the Council, SEND Partnership Board, Youth Justice Partnership Board. There's a whole range of those that we've looked at, the priorities within those. We've used the work that's been undertaken within those partnerships to help give us the overall picture of how the health and wellbeing strategy has developed. And the ongoing work that John's talked about will also come towards in the end. It's actually that we're trying to streamline, minimise duplication, work out where the crossover themes are to try and make sure we as across the whole systems partnership are working more effectively. And we've used this opportunity to take the health and wellbeing strategy as giving us an overarching view and approach that we all feed into.
Thanks, Graham. I think another key point which I would like to make is that the voice of children and young people, and we've incorporated that through work which has been done through the Children and Adult Safeguarding Partnership, but probably more so through the Children and Young People's Partnership. So I think we can strengthen that, and I think that's a theme through a lot of the work which Graham's just alluded to across the whole span of work with children and young people. An overarching theme is going to be securing the voice of the child. Oh, sorry. I just meant to say that what we would like to get out of today is really some discussion and feedback to shape the proposed priorities, to build on the work that we've done and in a way to sense check that, and to have some discussion about effective measurement of progress. The work which Graham's discussed, we have discussed indicators within that, and it's very much about how we land on some meaningful measures of progress which really look at closing the gap in inequalities. This is just a summary of the theme. The outcome was that all children and young people are happy, aspirational and socially mobile. And sitting underneath that with 3 priority areas. So the first one about providing the best quality education that we can. Secondly, ensuring that all children and young people feel safe and supported in all areas of life. And thirdly, supporting children and young people to make positive lifestyle and social choices. I'll just talk slightly about those. I mean, education, we know that education and high quality education has the biggest impact on inequalities and tackling long-term inequalities. So we wouldn't argue in terms of that remaining a significant theme or significant priority area. Likewise, ensuring all children and young people are safe and supported. It does touch on our safeguarding responsibilities, which collectively we have as organisations, but it goes deeper than that as well. And thirdly, and I think this is the priority area which we've proposed the biggest changes in, is around supporting children and young people to make positive lifestyle and social choices. The actions within the themes, there were a set of actions assigned to each of those priority areas. I'm not sure if you can see that clearly at the back. It probably doesn't matter so much at the minute. What I would say about them is that for each of those priority areas, there are some very high-level strategic actions and some very kind of quite granular level actions. So, for example, within education, one of the actions which was set was around undertaking a whole-scale review of educational provision, and then something very specific about ensuring that the pupil premium is being utilised to the best ability. And we have amended our proposed actions to make them kind of, I think, more tangible and some more specific, like in the previous theme. So we did challenge ourselves and asked ourselves whether these were the right priorities and actions going forwards for the next half of the Joint Health and Wellbeing Strategy. In terms of reviewing progress against national indicators, each of those priority areas had a group of national indicators assigned to them, And we've grouped those together, as you can see, by the action area. At the time that the Joint Health and Wellbeing Strategy was produced, there was the value assigned to that and a description about the trend. So that's the trend at baseline. Probably the thing to focus on is the far right-hand column. The ones in green, so if there's green, that indicates that there's been an improvement. So particularly there have been improvements in under 18 conceptions, breastfeeding rate, which is absolutely key for a number of health indicators for children and developing into adulthood, which probably don't need to go into the detail at this meeting. And also smoking status at time of delivery, linked to what you've heard in the previous presentation. There hasn't been improvement across all indicators. There has been a decrease in school readiness, and that was the data which was available at the time that we pulled this report together. Audrey may be able to comment further on that. I think one of the things that we would want to bring people's attention to in relation to these indicators is that they are national indicators, and national indicators, whilst they're very useful, they don't tell us the whole picture about Northumberland. At a very kind of high level or at county level, they mask potentially inequality and variation within Northumberland. There's a significant issue with time delay to publication. You'll note that one of the indicators here about exclusions hasn't been updated since 2016-17, and that's the nationally published data, whereas we know that within the education and skills team within Northumberland, we've got much more contemporaneous and granular level data. So individual services and individual organisations may well have some stronger information and stronger data which would help us to develop some better indicators. And for positive lifestyle and social choices, also, I think that raises a question about the indicators which are included in the original Joint Health and Wellbeing Strategy, whether smoking at time of delivery and breastfeeding, whilst they're really important indicators, whether they are really the best measures of whether children and young people are making positive social and lifestyle choices. I think they're really about parental choices. So as part of our work, as I described, we started to look at what narrative and qualitative indicators that we had, and we did look particularly at external inspections. For each of those areas, for education, safe and supported, and positive lifestyle and social choices, there are data from national inspections. So I won't go through all of these in detail, and these are just examples of the type of data we have. But certainly for education, we know that in 2022, there were the highest Ofsted ratings that we had. They may even have improved since then, but with well over 87% of primary pupils and 78% of secondary pupils attending good or outstanding schools, which is really a key measure for us. With excellent early years provision and very high uptake of uptake provision as well. In terms of safe and supported, the ILACS inspection, so that's the Ofsted Children's Services inspection, reported that children are helped and protected and cared for to a good standard. And importantly for SEND, following the 2018 SEND inspection, when there was a written statement of action, there's been significant improvement, as you've probably heard in this board and elsewhere, and further challenge and scrutiny, or the need for that, was removed. There's also some strong partnership working, including the development of a multi-agency and partnership emotional health and wellbeing strategy supporting children and young people's mental health and wellbeing. And we've talked about the development of the Northumberland Children and Adult Safeguarding Partnership. So a range of other indicators which we have, which measure and demonstrate really strong progress in all of those priority areas. Is there anything which you would like to pick up?
No, I think it's just reinforced the point about wider than KPIs effectively. And, you know, across those various partnerships, we will look at a range of ways of measuring effectiveness and impact, not least the voice and views and experiences of children and people, which we've talked about, but the range of external inspections, but also our own quality of practice framework, which we would talk about understanding the effectiveness. So again, just something for discussion here, I think, about trying to maximise the qualitative impacts we have, as well as just through KPIs, which is something we do here, and pulling together what we have got already through our range of partnerships and how we try and do that.
It would be really remiss of us not to mention COVID, like in the previous presentation. At the review point at 2023, we've had, or we are emerging from the COVID pandemic, which has had a disproportionate impact on children and young people. Important to really remember that 2 years of disruption is really significant in the lifespan of a child and can happen at some really significant points of development. I think we're all familiar with the disruption to face-to-face education, which happened in 2020 and 2021. Not to say that schools didn't close, education continued, but there was disruption to that, which has or had the impact of affecting children and young people's social opportunities. There has been an impact on mental health and well-being for some children, not for all children. There has been an impact potentially on school readiness, and I think it's really important to note that there's been a disproportionately impact on existing inequalities. So while some children and young people may not have experienced such significant impact from COVID, it has really impacted the more disadvantaged. And this has potentially been compounded by recent increases in cost of living as well. So it's really just to remember that this is significant and will shape the next 5 years of the Joint Health and Wellbeing Strategy. I think we're very much still looking at almost COVID recovery for some services, or dealing with the impact or ongoing impact of COVID. Our proposals for refreshing the theme were actually to rename it, so actually shift the name from Giving Children and Young People the Best Start in Life to Starting and Growing Up Well. And there's a specific reason for that, in that Best Start in Life has different connotations. It was first described by Marmot in the Marmot Review and highlights the importance of the early years of development, so particularly the first 1,001 days, but also the first 5 years. That is crucial, but it's a component of this theme, because really this theme is looking about starting and growing up well and preparation for adulthood as well. We propose that the priorities of education stays the same, but it would be education and growing up well, and we'll talk a little bit about the rationale for that in a moment. Children and young people being safe and supported, we would retain that, but actually amend the third action area about children's or being safe and supported into developing positive social and lifestyle choices. Amend that so that action area is children's physical and emotional health and well-being. And I'll talk about the rationale for our thinking behind that in a moment. It's really to include the importance of physical health, which that priority area has very much focused on emotional health and well-being, which is absolutely critical, but needs to be supported by physical health. And I think that needs to be brought, or the strategy could certainly be benefit by having that brought forwards. It emphasises, as I said, the holistic approach and contribution of all health and wellbeing partners, and it provides an explicit opportunity to link in other plans and priorities, such as Clause 20+5, related to children and young people, and that's the NHS approach to reducing inequalities. Within the education and growing up well theme, these are three of the core, or what we see as the key action areas which have been brought out. And rather than talking through them in detail, I think you can see from reading them that it's about inclusive education. So it's including all children and young people, including those with special educational needs and disabilities. And it's education in the round. It's not just about academic achievement, it's about vocational training, apprenticeships, further education, higher education, and employment opportunities. So really about preparation for adulthood and later life. And a theme through all of these is around developing and embedding partnership working with families. In terms of safe and supported, this is really a shared endeavour to safeguard, protect, help and promote the welfare of children, and we're proposing that this stays as a priority area but with amended actions. I don't know if you wanted to come in on that, Graham.
I mean, these are taking a high level, the priorities that are across the range of partnerships that I've covered, but the other bit that we do want is probably the bottom point, to make the point, the key element of workforce for us to deliver all of that. So, you know, across all our agencies, I know and I'm aware of, you know, some of the challenges we've got in terms of workforce. So hence that's why we've put that specifically in there. And I know there's work going on with the ICB looking at workforce, which is part of the committee, but again, joint endeavour to try and make sure we support, develop and recruit and retain our workforce to deliver what we need to do for children and young people.
And probably importantly highlighting in there the voice of the children and young people. So thirdly, this is the priority area which we wanted to amend or make the most significant changes, is around physical and emotional health and well-being. Again, there's the theme of partnership working, because we can't do this, or no single agency or organisation can tackle health inequalities or contribute to delivering the health of children and young people on their own. So it's very much a focus on partnership working. We've incorporated delivery of the Healthy Child programme through both an integrated 0 to 19 service and the Family Hubs offer. I think Graham might talk a little bit about the Family Hubs offer, because that is fundamental to delivering integrated children and young people services across Northumberland. There are representatives from all of the key organisations who sit on this board, so Harrogate District Foundation Trust, Northumbria Healthcare Trust and Northumberland County Council and others are key players within the Family Hubs. Again, focus on tackling inequality with particular emphasis, I think, on healthy weight and physical activity, as well as emotional health and well-being, because that is going to be a key priority going forwards. So I think in summary for this theme, it's really about embedding physical health alongside emotional health and mental health as well. In terms of discussion points, we'd really value feedback from members of the Health and Wellbeing Board about how well the suggested changes in the theme title, the priorities and actions, reflect collective thinking and priorities around young people. So particularly welcome feedback from NHS colleagues around how we might incorporate NHS approaches as well. What indicators and qualitative information can we use effectively to measure progress? So as Graham said, not just having some KPIs, if you like, but what's the rich data and the data that we can really pull together to show closing of the inequalities gap. And another thought that we had as we were starting to review this, and which has progressed as we've gone along, is whether we need to consider a different approach to the joint health and wellbeing strategy, whether it's for the review or whether it's for a further iteration. And this was fed by our thinking about whether we are actually starting to adopt a whole systems approach within children and young people, and whether a whole systems approach is an enabler which should be built in to all of the themes. Is it an enabling theme? And if so, to what extent have we adopted it within this theme already? So thank you, and I'd like to really invite questions.
Well, I think that we will leave the discussion points here, excuse me, on the screen.
Oh, sorry.
It'll be useful. Yeah, it'll be useful in case there are questions. Yeah, that's correct. Thank you very much. And really, I think, again, in this theme also, we have to look at the comment on the progress we made so far and the amendments suggested, and then we have to comment on it and agree it. Okay. In fact, I read the report very carefully. One of the things that struck me was very frank and accurate report. In some cases, you have said we made progress. In some cases, we haven't. Same way in Jim's report as well. And in some cases, you bluntly said, look, there are no data available. So I like that one, because we not only need to look at where we have done well, but what are the mountains to climb and the challenges we face. So it's very important, and thank you very much for that one. Thank you very much for all the good work. Now, if there are comments, I am happy to take one. Yes, Abby.
I love the refresh sort of terms. I think that they're much more meaningful and relevant. And I also welcome active language rather than passive when talking about sort of children, young people and families. And I also really welcome the inclusion of physical health, particularly when you look at the metrics about the increase of obesity and things like that, and actually the positive impact that physical health can have on people's mental health. It's just much more of a whole person approach. And when it comes to a whole systems approach, when you talk about workforce development, I would just welcome the inclusion from the voluntary sector as well, in terms of thinking about who is best placed to do those roles and in which sector. It doesn't always have to be statutory or schools. Thank you.
Yes, please.
It's quite sobering when you look at the data that shows us that we've actually gone backwards on many things in 5 years, isn't it? And then the next slide, which is the qualitative stuff, we're almost at risk of falling into the trap of saying, yes, but we're doing lots of good stuff, so it'll all come right because we're getting it right. So I think we have to be really careful that we don't look at that slide and say, well, obviously it's all right. What we have to say is, what else can we do now on top of this stuff to get to the bottom of it? The work that we've done on inequality so far, we haven't really mentioned today, but understanding our communities and which ones are the ones where the biggest gap is feels crucial in this. So we have to get on top of that. And then I was progressing that slightly and thinking, so if we are working towards neighbourhoods, and if you were a team of people working at a neighbourhood, it would be absolutely vital to know actually what are our touch points in this neighbourhood on these things which are not going well, and how do we mobilise our teams as a system around those very issues, and how do you decide which are the most important bits in that neighbourhood to work on? And that's workforce, so we've twigged that already. So how do we flex our workforce to get to these places where we could make bigger differences on the gaps? And then it just flows completely into the wider determinants. That we could concentrate entirely on wider determinants and think that there would be a solution here, and then that falls into the Northumberland plan, which is emerging, which takes us with much longer term, our anchor institutions, poverty. These are the things that really get to the bottom of this. So it feels like it's joining it up as a system and knowing where we're going, but bringing it to those bits so we're not complacent that, it'll all happen in the end because we're good at doing it.
I think absolutely, in children's services, just taking the points about whole sector and community-based, and along with the voluntary community sector, for us, excuse me, the key element is the family hubs for us in terms of the locality-based partnership working along with the voluntary community sector. So, for example, we're working with Thriving Together around developing youth offer and support for voluntary organisations in that, and there's a range of ways in which we can further develop that community link, the community asset building through our family hubs, but also the further work we can then do to increase and enhance our statutory services links with those. And there's a whole range of things around that, around stigma and all of those things that we need to think about. But if we are looking at a whole systems approach, that's the base on which I think we can take this forward effectively.
Hi, it was just to say that I think the report's great. I think the changes, as other people have said, are really welcoming. But I think not to miss off the confidence in young people. I think that needs to be built in. I know we talk about mental health and well-being, but I think confidence and self-esteem is something a little bit different. And I think the aspect of COVID has really hampered young people's confidence to actually leave their bedrooms, to get off a screen and do something different. And I think that relates to physical health and well-being as well. If you haven't got a set of skills or confidence in yourself to access those services or to get out into your community, you're not going to build your physical activity, or it's going to impact on your emotional health and well-being. I think a lot of young people have become very dependent on technology and phones, which on one hand is fantastic, you know, that's the way the world is moving, but on another hand really grows social isolation. And I think for our more rural communities that is a major problem, because they maybe haven't got access, as we've talked earlier today, about services that they can get engaged in. So I think confidence building needs to be mentioned somewhere in the report. And I think that has a direct correlation with family hubs and parents being those role models for that confidence as well. Because again, you talked about that school readiness, and I get COVID had a major impact for school readiness, but I also think parents have a role in being that positive role model for their children. And again, if parents are on their phone or on digital devices, they're not engaging with their children. So that getting parents to engage with their children and to be those positive role models, to install that aspiration and confidence, it just rolls on from there. Thanks.
Jeff.
Thank you. I think I first of all just want to say a huge thanks to John and Graham, who've been particularly tenacious in getting the whole of children's together and coming up with the new approaches. Graham started off by saying actually we had to work backwards for a wee while and look at the whole of children's, because to arrive at these we needed to ensure that this was going to be sustainable moving forward, and for all of the comments that everybody's made, make sure that we as a wider team are ensuring that each of these aspects has a pyramid underneath them that's building up the work towards it, that will start to take us forward again. You're absolutely right, Graham, in terms of looking at that, the statistics and the going backwards. We've got some amazing statistics, but actually the ones that matter are the really key ones where we're not making the significant progress. And that's at a local level. So we've got some county-wide really good stats, but underneath there lies, you know, some inequality that we're all talking about, we all know and understand and are definitely focused. The big bit for me that came out of this, you would expect me to say that I think the priorities are the right ones, the right words have been put in by our very valiant wordsmiths here who've pulled everybody together around this. But for me, this is about making sure that when children are growing up and growing well, starting well and becoming young adults and going on to be our employees and employers in Northumberland long-term or globally, whichever way around, we're doing the very best, that we're working alongside health, we're making sure that all of our communities work together is joined up, we're preparing them really well so when they become part of Neil's system and become adults into the county, that this is knitted together in terms of our overall work. And if Simon were here, our Director of Place and Regeneration, it's really also making sure that we're preparing everybody for the place of work. So there is a whole joined up system that sits underneath these key priorities, and making sure that in children's we play our part in the overall ability for Northumberland to be much stronger. It's really strong now, but much, much stronger and sustainable in terms of that strength moving forward. Thank you.
Yeah, Graham mentioned that when you look at these figures, sometimes you think, oh dear, that we're not doing quite so well on that particular one. The one that stands out to me, and I just wonder if we have a theory as to why it's happening, is the number of admissions to hospital by unintentional and deliberate injuries to children, which has gone up substantially over the last few years. I reckon that's 15-20% increase, and that's not a figure that I've been aware of before. I haven't seen anything that's reflected that. Do we have a theory as to why it's happened? Is it COVID again? Are we blaming everything on COVID, or is it something else?
I'll take that from a safeguarding perspective, and certainly nationally there's been an increase, and you'll see nationally reviews of children with very extreme injuries, including death and murder. And there has been an increase in that through COVID, through the lack of ability to keep eyes on as being part of that. And certainly in Northumberland we have, even more recently, seen an increase in incidents where we've had to report to Ofsted. They've met that kind of criteria. But what we always do with those is what's called a rapid review, where we review all the actions in relation to that taken across the partnership. And none of those have have gone anywhere other than one that we will do a further review to take any learning from. So the point, Jeff, that in safeguarding terms there has been an increase, and I think it's reasonable to assume that some of those are backdated to the impact of COVID, the pressures that were on families, and the lack of accessibility and eyes on and support that would be available. We're not talking huge numbers here, but I think we have seen an increase. And again, that's where the whole systems approach takes in. So the Safeguarding Partnership absolutely drill into and look at and review those ones, whether a safeguarding and protection elements.
I think if I can make a comment as well, in relation to that, it's nationally published data which is collected from hospital episode statistics, and that's dependent on how things are coded at a local level, so it's dependent on local practice as well. We have noted that North Tyneside has a similar pattern, and I think there is a piece of work which we could usefully do with Northumbria Healthcare Trust just to understand the data. It's not to say that some of that isn't real, but actually we need to understand the indicator. And I think that does highlight some of the challenges with using those national indicators and applying them at local level, whilst acknowledging the caveats and the things which Graham mentioned about not disregarding them either.
Chris is waiting to ask a question as well. One of the points, just building on that though, was just for fire and safety and police about accident prevention and the work that your organisations must do. And one of the things that would hopefully reduce would be accidental injuries for young people. So I just wonder if there is some conversation to be had somewhere, and you'll do it through the safeguarding points that you have. But it's a bigger thing than just that, I would imagine.
Yeah, no, totally agree. The other thing that I think would be useful locally to support your data and that indication is, I know we're talking about kids not going to school, but there's nothing there talking about kids who are reported missing. So from the home, from local authority care, because that's a really good indicator, and I think it'll be useful to track that, and often the health risks that then arise from those missing episodes.
Not a problem at all. Just to pick up on that last point around hospital coding, I'll try and make it brief because it's not the most interesting subject sometimes. There is stringent rules, national rules around clinical coding that obviously the Trust follows, or all Trust follows, to try and make it more standardised. But we'd be happy to work and do a piece of work around looking at that in more depth if that's of interest. Secondly, just around the kind of more of the change of emphasis around the mental health and bringing that out. I think that's something we'd welcome as well. That we're certainly doing some work within Northumbria around trying to pull together all the strands of our mental health services, adult and children's, which would certainly feed into this. And I think then putting the health inequalities lens onto that as well would be something else I think would be worthwhile to do. But when we're doing that health inequalities lens, I think it's always it's always interesting. It's really interesting to get those insights and to get the kind of I didn't really expect that, or I did expect that. I think then it's the so what, isn't it? It's like, well, what are you going to do with it once you've done that? And then is the vehicle for that then the neighbourhood teams and trying to get in at a local level, because the issue will be slightly different in each of our localities, each of our neighbourhoods. The response to that will be slightly different. I think then that brings another challenge of, not insurmountable, but another challenge around the data and the dashboards, which we've picked up on a number of times this morning. Because sometimes we have too much data, too much information to see. But often some of that information is around access, which is important, access to services, quick access to services. But we also need to be mindful, I think, around making sure that we also have the back end of that data about, okay, you've got that service quickly, but did it do what you needed it to do? Did it improve your health? Did it improve your your situation. I think we just need to be mindful, make sure we tease out some of that as well as the information around access.
Thanks, Chair. Three brief points, if I may. First one around language, and back to your point around whole systems approach, and should that be an enabler throughout. Interestingly, I was with VCSE sector a couple of weeks ago, and there was some rightly supportive challenge, as we shall refer to it as, in relation to the language of system and what does that actually mean. So there's perhaps something about paring it back around collective responsibility, or so I completely agree this will come up in all four themes, and Jim, it was a question from yourself early doors as well, so maybe that is a language point for us around, we might all understand what we're talking about when we say whole systems, but if we want to engage that wider voluntary and community sector, then actually that's quite jargonistic, so that's point one. The second one around physical health, and it's back to when you mentioned about the core 20+5. We've spoken around physical activity, we've spoken about obesity, but actually it might be something if you want to have a further conversation, potentially in the primary care network, or Lynn, I'll take your advice and Graham's around the asthma indicators and things like that, that do actually contribute towards why some children don't go to school, for example, and we've got quite significant inequalities in those areas. So it's worth exploring to see whether we do want to add them into this strategy, or do they belong somewhere else, so therefore they don't need to be here. But let's just, I suppose, close the loop so we know where they do sit if they don't sit here. And the third point was in relation to the, where we're working towards in relation to a county partnership, and we talked about in the inequalities event around changing that generation, which is 20 years. But actually, if this is the first 5 years of those 20 years, then where do we want to be in 5 years' time? So I suppose it's that challenge to ourselves is, well, what will good look like for us in 5 years' time against these indicators? Not necessarily saying we need to set targets for ourselves, and that will be something that hopefully the Institute of Health Equity will work with us on, but just to have that in mind, I suppose, for us all as a board around that level of ambition that we want to have.
Graham, you wanted to add something?
Yeah, just a very brief point, absolutely, about the missing information. That would be scrutinised by the Safeguarding Partnership, and equally there will be stuff about diversion from crime that will sit on the Youth Justice Board. But I think it's absolutely right that the questions are asked of here, and even if it's about where we pitch and how much detail we put in. But I think it's absolutely right the questions are asked, and if long we can come back and ensure that, yes, this is looked at in this part of the children's system, absolutely that, and that's, I think, just a good example of how we could mix it between.
Thank you very much. I think if time permitted, I wanted to, in fact, ask a question which I think Jill probably addressed it. This is about the last point, is a whole systems approach an enabler. I always assume the whole systems approach cuts across various themes, and then it plays its role in taking input from various partners and then working the objectives together collectively. In that sense, I also include decisions makers and cabinet members as well. The whole system includes that as well, actually. I mean, I think Audrey put it very nicely. There are lots of pyramids, but at the bottom of the pyramid, there are lots of unrecognized sources of inequality, or difficult to recognize sources of inequality. So in that sense, I think the policymakers in the council also have a responsibility, because often, from what I have seen, there is a tension between, do we spend lots of money on a single project, or do we do it on multiple projects so that it addresses the other types of needs? So the HS2 is a very good example. I had a mixed reaction, because then Glenn told me that, no, that part of money is not disappearing, but it is going to go to several development work in the transport. So this is a kind of a policy decision we also have to have in mind, because HS2 spends billions on a single project. So do we do that, or we take that money, divide into mini projects addressing various things? So in that sense, the whole systems approach also includes policymakers and advisors and everything. So I always thought this is a definite enabler, and it should be adapted in this theme as well as in each one of the other three themes, actually. Is there any contrary opinion? I'm ready to be corrected if there is Yes, my vice chair is...
It's not a contrary opinion, but Jill's point has got me really thinking on that whole systems language, because I think that does make it feel like it's the service's responsibility as well. And I think probably we do need to have a bit of a debate about whether there should be a change of language right at the top about everybody's job, or I don't know, there's some different words that we could use that certainly bring it into the focus of, for Cormac Russellstone, the citizens, you know, because it's their job as well. Yeah. It's not just us.
We had a very good discussion. Is there any other comments, suggestions, questions? No? Okay, thank you very much. In that case, we can move on to the next item. Thank you. Thank you for the presentation, both of you. Thank you. Abhi Kanwe, a passionate believer in enabling the voluntary group, so I really look forward to hearing this report as well.
Hi everyone. Yes, I am a passionate believer in system approaches. Actually, that system includes the statutory players and also the voluntary sector and also communities themselves. For those who are less familiar with Thriving Together, I just wanted to give a little bit of background to the project. So in sort of August, September 21, Northumberland County Council commissioned Thriving Together as the support system for the voluntary sector in Northumberland, with a set of defined deliverables. The underpinning ethos was to give all organisations within the voluntary sector the opportunity to thrive and achieve their potential, with an aim to showcase the work of the sector through collaboration and more partnership working and cross-sector partnership working. I'll say that a few times. Our approach is different to a lot of other sort of voluntary sector support in that we want it to be inclusive by offering non-membership based support and to try and make that positive impact on Northumberland residents. And we're delighted to have had that commission extended for an additional year in recognition of the transformation of that VCSE support that we've delivered. So those deliverables there, you know, the providing support to connections to operate safely and legally, that's around governance and compliance information that we act as a conduit to existing resources that exist. Actively managing the relationships is leading that collaboration within the sector through multiple networks and partnerships, which I'll talk about in a bit. Northumberland Communities Together is a critical relationship with Thriving Together. We've established a close working relationship with the team at every level, and we have regular touch points to exchange information and provide that strategic input, which has been really helpful, especially whilst we've been tackling things like the cost of living crisis and the energy crisis, to be able to activate you know, the sector. And then developing those relationships within and amongst the sector, making sure that we offer the best fit representation and really capture the quietest voice, so that it isn't always my voice you hear, because that's not my job. That, you know, I'm to act as that conduit. So firstly, we wanted to develop that central point of information, and that was the website. We've got within that website, there are areas like collaboration, events, jobs, volunteering, and that's sort of set up by March, April 22. We've had over 22,000 hits on that website, so it's clearly been getting use within the sector. We've also looked at improving communications through other sites. So we've got social media platforms, Twitter, Facebook, LinkedIn, and we've reached over 30,000 people within an 18-month period. So there's quite a good reach. We do have a wider impact, which I'll get sent out to you, so that the full impact report, which details exactly what that reach and stuff is. But this is just a very brief summary. We have a bi-monthly newsletter. We have over 300 subscribers that it goes out, and we also do quarterly events, which we we took the sector's perspective. They didn't want to be talked at, they didn't want to be talked to, they just wanted to come together and actually network with one another. And we're rotating them around the county, which they've been very well attended and some excellent feedback received. And we also have some community connectors, which feeds into that neighbourhood teams that you were talking about before. They're the ones who are talking to individual organisations, having that one-to-one visit, of which we've had over 300. And that's about making sure that the smallest grassroots, hyper-local organisations are connected to what's happening up here, and what are these strategies that people are trying to sort of do, and how do they interplay there. So a lot of those organisations haven't previously engaged, they've just done their thing, and a lot of them obviously came post-COVID as well. You know, they stood up during COVID, and it's about what's their role now and how do they implement that communities first and best work that's kind of going on. We've also concentrated a lot on our networks. There were already some existing networks within Northumberland, but what we did was use some of the money through the Commission to actually build the capacity and develop new networks, so that nobody can attend every single meeting. You know, no one has that capacity. So what we tried to do was organise networks around themes or around geographies, so that different organisations could choose the network that best served them, or the place where they felt they could, you know, the issues were most prevalent. So those are some examples of them. But, you know, we've got equity, diversity, inclusion. There's the Nourish Food Sustainability. We've got a health and wellbeing network. And there's also a link there to what we want to do going forward in terms of how we want to develop additional and new networks. But what's really important is that we close the ring on that. So we have a quarterly meeting with all the network leads. We make sure that there's a forum for information exchange. So it doesn't matter which network you're part of, you still get the same information. Because what we don't want to have is this thing of people on the inside and other people on the out. We don't want to create a clique kind of culture. We want to make sure that because information is power, and we want as many people as possible to have that. We also use the networks to feed our touch point within the local authority, which is the VCS liaison group, which has elected members, some of which are here today, who attend. We actually ask for agenda items. Previously, that used to be very much led by, this is what's on the agenda, this is the strategy, and what do you think of it? Now it's a co-produced agenda which talks to the things that are affecting the voluntary sector and also the communities that we're serving. And some of those topics have been around community transport, asset transfers for community buildings, cost of living crisis, the integrated care system, what does that look like for us? And then most recently about social value and commissioning. And then again, it's that thing about not just being my voice, it's representatives from the VCS themselves come to talk to that. Myself and my colleagues provide support to them, so if they're giving a presentation, you know, we might help them to be able to feel comfortable doing that, but it's about hearing from them and us acting as that conduit to ensure that voice is amplified, and actually, you know, we can try and affect change at a strategic or a system level. So, you know, I mean, most recently when I talk about that, the social value, there was an incident with, you know, a local charity who lost out on some core commissioning work, and the contract went to a national organisation, nothing wrong with that, with no footprint in Northumberland. And it was, you know, but it was because the local organisation weren't able to articulate the added value that they provided through that core grant, and actually the added value that gave to the local community. And the response has been fantastic. You know, the county have recruited a new social value commissioning manager who's coming to talk to the next VCS liaison group. So it's an ongoing dialogue, and it's something that's moving rather than it being a talking at shop. In addition to the networking events that we hold that I mentioned before, we also attend and contribute to multiple other showcase events, things like the Health Inequalities, you know, Summit, the Inequalities Locality events, the Health and Wellbeing Conference. We also worked with the Department for Levelling Up around the Hello Her stuff, and actually school readiness was something that was a key element there. But also, you know, I was on a call with Graham this morning with other ICB leaders. We have attended the System Transformation Board, and obviously our presence here. It's about making sure that I disseminate that and issues are escalated in both directions. One of the most important functions for Thriving Together has been to build capacity in the sector and to provide leverage for additional funding. For example, there's a case study with Northern Cancer Voices. They were an unconstituted group that were working around amplifying the voice of cancer patients to try and improve services. They had received some funding, but they didn't have a bank account, and they didn't have any governance, and they didn't have any trustees, so didn't have anywhere to land it. So we hosted that money for them. We recruited somebody and then seconded them out to them. So that person's now been able to go and recruit volunteers, chairs from across the whole ICS area, so from Berwick across to Cumbria and down to Teesside, in order to kind of collate and amplify that voice at a system level for the ICB. They wouldn't have been able to do that without our assistance, but we've actually, as part of that transition, we've now worked with them on constituting them as an organisation, work with them on the governance document and about getting trustees so that actually they can take that money and move that forward because when it's right for them. We did these slides a few months back, and in the first 18 months of Thriving Together, we'd managed to bring in an extra £2 million. So for a £200,000 investment, we brought £2 million of additional income into the sector. There are restrictions for small voluntary organisations when they're applying for funding. Often there's a minimum contract value, and if you're a very small organisation, you just can't apply. So by collaborating, coming together, and working as a sort of as a prime sub relationship in conventional terms, but actually being much more at a peer relationship, we've been able to bid for money from North of Tyne Combined Authority for the Multiply programme, which is maths, but not in the classroom. So it's all kind of functional and practical maths, because the North East and in Northumberland, we have really low numeracy rates. We've also worked on the Solid Foundations, which is the employability project from North of Tyne. And our most recent success is around the adult education budget, looking at some of the really small providers that do community level learning, again, who wouldn't have been able to access that without it. Another example is actually using us as a hyperlocal fund distributor, which we did on behalf of the Hello Hurst I mentioned, which was a partnership with People and Places, where we tested the development of that model of application, the distribution and impact of very small grants. It was about £50,000 to local providers that were working on that work around school readiness, community engagement and enrichment activities. And then most recently, we've just had a £250,000 investment around population health management and health inequalities, which we had a pot of money allocated around small intervention work that voluntary sector organisations could do to contribute to that theme. And we convened a panel of experts from across public health, the ICB, and other partners to opine on those projects. And then Thriving Together will be managing them and making sure that they are delivering, giving that quality assurance and giving that ability to track the money and making sure we're getting best value. This map shows the reach. So, and some of the connections that we've made. We can say that we've got full county coverage from across the north, and you know, where there's big sparse gaps, there's not many people there. It tends to be the Northumberland Park area. But you know, we have, because of our connections with the networks, using existing networks like the North Northumberland Voluntary Forum, which is a very well established partnership up in the north, we, rather than do something ourselves up there, we gave them the money to convene their meetings and gave them access to everything else that we were doing. So it's not about replicating, it's about working with what's already there. But we can talk that we do go down to real grassroots groups operating from just a few streets or a neighbourhood, all the way to the larger county-wide organisations. Other stakeholders, as well as Northumberland Communities Together, you know, we've established a very strong working relationship with them, but also across the rest of the local authority, you know, colleagues within public health and within education, and because that system approach is really important, and I think we've talked about those wider determinants of inequalities. Actually, there isn't a silver bullet, is there? There isn't just one thing, and I do take on board, you know, what colleagues said before about that early start and best start in life, and actually that throughout education and transition to adulthood, that's something that we see an awful lot of. It's kind of, how do people make that next transition point? And all the information that we receive from all of the networks that we do, either ourselves or anything, it's all about collecting that intelligence and dispelling it either through social media, through the networks, through the events and everything like that, because everybody receives information in a different way. So we're trying to kind of catch all bases, I suppose, with that. Over the next 12 months, we want to develop a VCSE leaders network, kind of like a professional senate, because it can be quite a lonely place. As the chief exec of a charity, I know that. So, you know, and you don't want to look like a complete idiot in front of your chair of trustees. So it's useful to have somebody else to kind of bounce that off. And there are also organisations that don't necessarily fit any of the networks, so they were looking for a home. And this is a request from the VCSE themselves. We've also been very grateful to be part of the Inequalities Action Plan and the Inequalities Task Force that's come from that. So all of the Thriving Together networks are represented in that task force, and we're looking at the Empowering People Communities theme, and how we can add sort of meat to the bones of that, and how we can kind of kick the tires of it, similar to what colleagues have done around refreshing it and looking at the language and also the tangible, measurable outcomes. The hyperlocal funding, we're quite keen to develop that and move forward with that, and obviously we are looking for the other opportunities, but also the development of the volunteer skills passport. We want to make sure that people they can volunteer with me at CB, or they can volunteer at the trust, but they shouldn't have to do safeguarding training twice. They shouldn't have to do all of those things twice. They should actually be able to have a movable passport which enables them to give of their time freely, and it not just be a waste of, you know, we shouldn't waste the time that they're giving. So we want to keep going with the networking events. We chair the Northumberland Frontline kind of development alongside colleagues from within the county and within the trust and ICB. So we want to get more people on it. It's growing, and I can talk about that another time maybe. And we've got a revamped website with a dedicated funding page, because we want to. That is the big challenge that the voluntary sector faces. It's sustainability. It's not about funding per se, but it's about sustainability. And one of the key things that the approach we take is that money comes last. You know, what we try and look at is what's the problem we're trying to solve, who's the best placed organisation or person to fix it, and then the money conversation comes last. That's me.
Thank you, Abby.
Any questions?
It was an interesting update. Are there any questions to Abby? Yeah, Graham.
A lot of what you've talked about here comes down to that mantra of moving at the speed of trust, which seems really important in your sector, because often it is close to the ground and things need to happen quickly and people become impatient, and if there aren't levels of trust there, things become more difficult. And what I have observed, I think, over the last year or two is an awful lot of work on relationships to build that trust, so then the sector can move at speed and things can happen.
Absolutely, and people are jaded by previous experience, and I think we have to acknowledge that. But you know, there's been an awful lot of work to try and overcome that, and to try and recognise, you know, where things have moved. And so by inviting people in, you know, there are people who've maybe been a bit detractors or have kind of been a bit more challenging. That's great, because actually through challenge we improve. So rather than silence those voices, I think it's really important that we include those voices and say, can you come to, you know, you have that issue, you come and talk to that issue. I can talk for you, but actually why not just let people hear from you, and continually to go back and ask, you know, who wants to talk to that particular topic. And I think that's when we'll start to see real movement and real progression with some of those as well. But yeah, it is, and it's ongoing and it's constant.
Is there anything that we can do that helps with that?
It's really hard, Graham, because, you know, the ICB obviously was a new institution, and it's going through another iteration again, so that you can't affect that. But obviously from a voluntary sector perspective, people are sat there going, well, what's going to happen? You know, when are we going to get decisions on things? And so yeah, stop changing, that'd be great. Stop any more changes, that would be awesome. Make some decisions, and that would help. But you are communicating that. It's just sometimes the world that we're in is, you know, we're living day to day. We're living hand to mouth and we're living day to day. So it would just be about understanding when there's a challenge, understanding where that challenge possibly comes from as well. and being empathetic on both sides, I think is really important.
Can I just emphasise we'd like less change too? So I'd be quite happy with that. But no, I think that was a great example of where we need to start with neighbourhood teams.
Any other? Oh, yes, good job.
Thanks, Abby. I think it's always really important to make sure we shine a light on Thriving Together and what it is, because otherwise it can just be a name that's bandied around. So really appreciate your time to do that with us today. Again, going back to the VCSE task force that I've got the privilege of chairing, and it's really great to hear that perspective loud and clear. And something I think that is worthy of sharing with the board is around we're all continually grappling with locality coordinators, social prescribers, community connectors. And I think it was Jane Hartley, the previous chief exec of Vaughan, who said that we've got a lot of travel agents, but actually it's the destination that we need to focus on, and that's the capacity of the voluntary sector. So I think, including myself, we all need to be very minded when we're talking about a communities first model. We're talking about prevention in the community to de-escalate demand from statutory functions. We can't just assume that there's capacity in the system to do that, and that's certainly something that I've taken away loud and clear from the sector. There is the absolute willingness, want, ability, professional capability, but it's about the resourcing to do that. So we're listening.
It does feel that way. It does feel that, I think someone just mentioned before, the language that's used. Before it was kind of, we were all speaking in different languages, and that isn't just from a voluntary sector perspective. I think police, and actually it does feel like there's a lot more, I understand a lot more of what's being said. And I hope other people do when I talk as well.
My final comment is, I think it led to a good discussion. Nice to see the whole thing. Yes, we will definitely take it on board. Too many changes are not good. And of course, you are also well placed, isn't it? You also wear two hats. One is the chief of Citizens Advice Bureau, so you are able to get some intelligence which often escapes people. So you pass it on, and they're thriving together. So thanks for the good work you are doing. Keep doing. We will keep meeting. Thank you very much. Yeah. So that leads us to go to the sixth item, forward plan. I think next meeting we are going to discuss the remaining two themes of our joint health and well-being strategy. And what else? And there are lots of packed items for next month meeting. Some tobacco, mental health, and everything. So if you have any general comments on the future meeting, agenda of future meetings, please contact me or Leslie or Jill. Yes.
Sorry, just to briefly highlight that, actually the wider determinants theme is going to come in December because it's too full, the November one. So we're just going to stagger that because we do want to have quite a bit of discussion. And then it'll all get joined together, hopefully by February, so we can all see what the fully refreshed joint health and wellbeing strategy plus proposed indicators would look like. So just a clarification point there, Chair.
Yes, that is the plan, yes. And they are not 4 isolated discussions, but they are going to come together in the form of a strategy. Okay. Urgent business, I think you wanted to say something, Jill, in any other business? No? It's done. Okay. There is no, if that is the case, then there is no other business. So just to remind you that next meeting is 9th of November here at 10 a.m. Okay? So thank you very much for attending and all your contributions. In fact, this meeting there are lots of discussions in this particular meeting. I really feel that's what I was expecting, so I'm very satisfied with all your input. Thank you very much.